wonderful time that we've had together, and I'll allude to that just in a second. So today I'm going to talk a little bit about intrahepatic cholangiocarcinoma. It's a disease that I've focused a lot of my career on in the last 15 or 20 years. When I was graduating from fellowship, now 20 years ago, believe it or not, I was trying to identify a disease site that was relatively understudied. A lot of people have been studying colorectal cancer, hepatocellular carcinoma, but there really wasn't much understood about intrahepatic cholangiocarcinoma at least 20 years ago. Part of the problem was that relatively rare disease, I'll show you it's more frequent now, but relatively rare disease, and even at major centers like your own, not that many cases. So one of the first things that we did, 15, 18 years ago was put together an international consortium of institutions from around the world. So in North, South America, Asia, Australia, Europe, and then very importantly, your own institution. So our relationship with Soren and Professor Popescu goes back 15 years. We've been sharing data, collaborating, and I think we have well over 100 publications together on this topic and other topics. So I'm very indebted to you for your friendship and your trust to collaborate with us, and it's been a very productive collaboration. As you'll see, as most of the work today is presented from the data that we collected. So, this is an important slide, I can't miss this. So this is just a little bit of representation of my last 3 or 4 days here in Romania. And there's one quote that I'll never forget from Professor Popescu is aggressive hospitality. And I would definitely characterize the last 3 to 4 days as aggressive hospitality. I can literally not imagine a more gracious host than Professor Popescu and Soren, and also Yulia, who came and spent the entire Sunday with me. Your country is unbelievable, unbelievable. My only regret is I did not come sooner. And it's just a beautiful country, wonderful people. I've learned more about history over the last 3 days and had some wonderful conversations with Professor Popescu about theology, and that I'll long remember, so I'm very, very grateful. So today, I'm going to talk a little bit about intrahepatic cholangiocarcinoma. I had the benefit of being on the ILCO guidelines, the International Liver Cancer Guidelines, and where we outlined the whole range of topics with intrahepatic cholangiocarcinoma, and these guidelines are currently being updated, but I thought that we'd go through these kind of in sequence. So as I mentioned, intrahepatic cholangiocarcinoma is still relatively rare. As you know, similar to hepatocellular carcinoma, there's a significant geographic variation throughout the world, with the incidence in the United States being about 1 to 2 per 100,000. Obviously, it's higher in Asia because of hepatitis, but also aflatoxins. So one common theme is that any chronic liver injury that could cause hepatocellular carcinoma can also be associated with intrahepatic cholangiocarcinoma. And then also in Thailand, I was actually in Bangkok a couple of years ago, and I was talking to the Minister of Health. In northern Thailand, 85 per 100,000. Very, very high levels of intrahepatic cholangiocarcinoma. Why is that? Because endemic liver fluke in that area. In the most Western countries, we have seen that there's actually been a little bit of a decreased incidence in extrahepatic cholangiocarcinoma, Klatskin, and distal, and an increase of intrahepatic cholangiocarcinoma. Now, why is that the case? I think it's for 2 reasons. One reason is it's a misclassification bias, right? So maybe 10 or 20 years ago, when there was an adenocarcinoma in the liver, it was adenocarcinoma not otherwise specified, right? The hepatopathologist wasn't comfortable calling it an intrahepatic cholangiocarcinoma. But I do think that there is a true increase in the incidence of intrahepatic cholangiocarcinoma. And as I mentioned, the risk factors vary based on where you live in the world. Obviously, flukes are more common in Thailand, PSC, choledochal cysts, more common in Eastern countries. But at least in the United States, the main driver right now for the increased incidence of intrahepatic cholangiocarcinoma is NASH and NAFL, non-alcoholic fatty liver disease. With the epidemic of obesity, we see many patients with this fatty liver, this steatotic liver. And as I mentioned, any stress to the liver, an oxidative stress that's associated with steatotic liver can cause intrahepatic cholangiocarcinoma. And actually, that's the most common patient I see. Usually it's a woman, in her 50s, in her 60s, overweight, obese, dark liver, right on MRI, full of fat, intrahepatic cholangiocarcinoma. So I think that's why we're seeing a lot more intrahepatic cholangiocarcinoma, at least in the West. Now, over the last 10 to 20 years, we've really got a better understanding of the molecular pathogenesis. Maybe I gotta stand a little bit closer for the clicker to work, of this disease. And there's multiple different pathways that are in play. And this is a study that we did almost 10 years ago with our colleagues at Massachusetts General Hospital using our international database of resected intrahepatic cholangiocarcinoma specimens. And they did a genetic mutation analysis. And as you all know now, but we didn't know too much back then, is the most common mutations, not unsurprising, KRAS and BRAF, which we see in other GI tumors. But really the story that was interesting here was the high incidence of IDH mutations, right? IDH1, IDH2, mutated in probably about 15 to 20% of patients. And interestingly, although we study biliary cancers kind of as one group because they're relatively rare, there are definitely very distinct molecular profiles even among gallbladder and cholangiocarcinoma. And as can be seen here, for perihilar or the Klatskin or for gallbladder cancer, you see a significant higher incidence of P53 or KRAS mutation. But in patients who have intrahepatic cholangiocarcinoma, you see this much higher incidence of mutations in IDH1 and IDH2. So again, when we think about cholangiocarcinoma, gallbladder cancer, there's very distinct patterns with regards to the genetic mutations that allow us to kind of categorize these diseases relative to prognosis. And to that point, this is a study that I published when I was at Hopkins with Dr. Bob Anders, one of our pathologists, that showed that patients who have KRAS or BRAF mutations, not surprisingly, have very poor outcomes after surgical resection, median survival of only 1 year. And perhaps more interestingly, there's been a lot of focus around IDH mutations and trying to come up with different subtypes of patients. And this is a paper that we published in Nature Genetics that showed that IDH1 mutation can be prognostically important. And you can see here that patients who had IDH mutations, that their median survival was significantly worse in the range of about 2 years. And later on at the end, as we well know, is that these things are not only prognostically important, they're also therapeutically important because now they can be targeted, right, with targeted agents. And then the other paper that we published, because a lot of interest around immunotherapy, is that there is a subset of patients, it's small, probably only in the range of about 5%, who have mismatch repair gene, perturbations, and may be amenable to PD-1 therapy or immunotherapy. And here you can see in this figure kind of the outlay of the different mutations that are commonly associated with intrahepatic cholangiocarcinoma, again with IDH1, 15 to 20%, and then FGFR being very important. And largely these aren't mutations, but these are fusions that are important, that can be targeted. But it's also important to note that you really need to look at all of the potential mutations, right? Because there will be, as they say, like a long tail, right? When you look at the graph, yeah, okay, most people maybe have IDH1 or FGFR, but there's going to be a tail where there's going to be people who have, other things that you can potentially target, and that's really this whole notion of personalized medicine. So let's talk a little bit about the clinical diagnosis and management of this disease, since I am a surgeon, and that's what I do for a living, is see these patients and hopefully help them with surgery. So not surprisingly, these patients present much differently than patients with hilar or distal who present with jaundice. These patients often present with a asymptomatic mass or have some vague symptoms. Or as I say in the United States, if someone comes in and they stub their toe, they get a CAT scan of the abdomen. So there's lots of these that are picked up incidentally in the emergency room. And you can see here's a large mass in the right hemiliver here. And then typically what happens is that someone sees the mass, they're going to put a needle into the mass, right? And then you get back adenocarcinoma. And then the question is this a primary adenocarcinoma or is it a secondary adenocarcinoma from an unknown primary? And the hepatopathologist will typically look for biliary dysplasia and then do IHC staining to look for a pattern of IHC staining that will rule out a potential other primary like lung, colon, and pancreas, and then look for these markers that would suggest more a biliary primary tumor. So it's not infrequently that the hepatopathologist will come back adenocarcinoma, very likely, biliary in origin. That being said, we still, work the patient up. We get tumor markers. Tumor markers tend to be specific but not overly sensitive. So there is a subset of patients who will have completely normal tumor markers despite having advanced cholangiocarcinoma or advanced hepatocellular carcinoma. So we really can't always hang our hat on these tumor markers. I do look for a potentially occult primary tumor. I've had patients referred to me for cholangiocarcinoma who have ended up having a gastric cancer that we found on upper endoscopy, or have had a colon cancer that was missed. And so I'll routinely make sure that at least they've had a lower endoscopy. But really the workhorse of working up this disease is cross-sectional imaging, CT, MRI, and then we actually use a PET a fair bit, and I'll explain why we do that. Now, when thinking about how this disease presents in the liver based on radiographic features, there are three different morphologic subtypes for intrahepatic cholangiocarcinoma. There's the mass-forming type that typically presents as a low attenuating lesion, and if it's near the capsule, you'll see this capsular retraction. There's this periductal infiltrating type, and you can see here this duct that has a thickening of the wall and enhancement of the wall. And then the third type, which is the intraductal growth pattern, which you can see this ductatasia in panel C with those arrows, and sometimes you'll see an intrabiliary papillary mass. But in general, when we are talking about intrahepatic cholangiocarcinoma, and most of the data published on intrahepatic cholangiocarcinoma is the mass-forming lesion. These are data from the Liver Cancer Study Group of Japan, and at least in their large series and in our large series, about 80% of the tumors that are characterized as intrahepatic cholangiocarcinoma are the mass-forming type. Now, as I mentioned, cross-sectional imaging is very important. It's usually relatively easy for a hepatoradiologist to differentiate an HCC from an ICC on CT or MR. Because usually for the HCC, you have early enhancement and late washout. But it's the opposite for intrahepatic cholangiocarcinoma. These tumors tend to be very dense stromal tumors. So in the early phases, they tend to be hypoattenuating, and only on the later phases do they tend to enhance. So kind of the opposite, if you will, of hepatocellular carcinoma. If the tumor is small, sometimes it can be difficult, HCC, ICC. But if it's a big tumor like this, usually the radiologist will tell me highly suspicious for intrahepatic cholangiocarcinoma. And then the other thing we look for is this kind of peritumoral ductal dilatation that you can see there. We tend to use a lot of MR at our institution, and these three panels kind of like are the sine qua non, is like the classic, intrahepatic cholangiocarcinoma. You see in panel A, it's a little bit hard to see, but it's a hypoattenuating lesion, and then you can see the capsular retraction. And then in panel B, it's later phases, and you can see that this peripheral enhancement of the tumor, there's central necrosis. And then in panel C, you can see this black arrow, it's pointing to peritumoral ductal dilatation. So if a radiologist saw this, if I saw this image on MRI, this is classic intrahepatic cholangiocarcinoma. The other thing is that we do use a fair amount of PET because these lesions are very PET avid. And when you use PET, you'll detect occult metastatic disease in 20–30% of the time. And it may be intrahepatic metastasis, but perhaps more commonly, it will be nodal metastases, right? Either in station 12, station 13. And at least in my practice, if a patient presents with nodal metastases, I typically treat that patient with preoperative chemotherapy before I take them to the operating room, even if they're resectable. And I'll explain why, and I'll show some data, but that's largely because this disease has a very guarded prognosis, even with curative intent surgery. And when patients have metastatic disease in the nodal basin, their risk of recurrence is significantly higher. So I like to treat them with preoperative chemotherapy and then take them to surgical resection. So I've already told you we have our international database now. I think we have almost like 2,000, patients with intrahepatic cholangiocarcinoma and the database. But when you look at surgical resection for intrahepatic cholangiocarcinoma, these are usually tough operations, right? Patients, since it's a parenchymal lesion, they can get quite large in size before a patient presents. They can be in difficult locations. Here's a mass. It maybe doesn't project that well, but it's a large mass. It's in the right hemiliver, but you can see it's going over into segment 4. It's obstructed the right anterior pedicle of the portal vein. And so, this patient's needed an extended right hemihepatectomy, and you can see here the specimen umbilical fissure and the bile duct down to segments 2 and 3, and had to resect the extrahepatic biliary tree for this patient. And then here's the specimen, but you can see large tumor, sometimes hard to get a very wide surgical margin. And here's another patient, different patient. So this is a patient that recently presented. You can see has a large mass in the left hemiliver. You can see the right hepatic vein up there on the, I guess your left, but you couldn't visualize the trunk. You couldn't visualize the middle vein or the left vein. So it was unclear whether the tumor was invading those structures. This patient had a very high CA19-9, it was like 1,000 or something. So I gave this person preoperative chemotherapy. We used gemcitabine and cisplatin for this patient. And they had an okay response, but not great. The CA19-9 came down a little bit. So rightly or wrongly, we can discuss. I actually treated the patient with a Y90. I tried to do like a low bar, radiotherapy and treated the left, hoping that, that thing would shrink. Nothing happened. The Y90 did nothing. So I ended up, you can see here, just taking the patient to the operating room. Come to find out I could get the middle vein off, did an extended left hepatectomy on the patient. But on the explant, it was like 80% viable tumor. So the chemotherapy and the Y90 really didn't do much. This patient is still alive, about a year and a half, 2 years out. This is a different patient. So this is a little bit different. This is a patient who had a large tumor in the right hemiliver, was jaundiced. bilirubin was, I don't know, maybe like 12 or something like that. Also had ascites, and then had CA19-9 like 50,000. Very, very high. So obviously, I'm a surgeon. I wouldn't show you the case if I hadn't taken it out, right? Because I don't show cases I don't take out. But it was a hard decision. So we gave this person a lot of chemotherapy up front, and the ascites actually resolved. The CA19-9 came down, but it was still, high, 1,000, 2,000. But talked to the patient for a long time, tried to decide, talked to the medical oncologist for a long time, ended up taking the patient to the operating room and did a right hemihepatectomy. Recurred. 6 months later, patient recurred, patient died. It was after that recurrent disease. So I think the two cases just show, hard decisions, right? Big operations. Maybe the first one was the right thing to do. Who knows? Person's still alive. This one, very high CA19-9. Patient had ascites. Probably not the right decision. But, when you go to the operating room, there's a lot of conversation like hepatocellular carcinoma. Do we need to do an anatomic versus a non-anatomic resection? Does it make a difference? at least the data from Professor Popescu's and my data set, shows that it doesn't matter if you do anatomic versus non-anatomic. But what does matter is getting a negative margin, just like colorectal cancer. You get a negative margin, and the survival, both recurrence-free and overall survival, is better. So ideally, as surgeons, we should try to get a 10 millimeter margin, a centimeter margin when we do these operations. Now, to do that, sometimes we have to do vascular resections. We have to do a portal vein resection and reconstruction. The data would suggest that you should do that, because if you do that, you get a negative margin. Long term, those patients have the same outcome. Short term, morbidity is much higher with those operations, and that it should be done at a center that has a lot of experience. So what about staging? We talked about resection, so after you take it out, right, what do? We typically send it to pathology, and the pathologist looks at it, and they come back and they tell us the stage, right, based on AJCC and UICC. So what's interesting about intrahepatic cholangiocarcinoma is for the first 6 editions of the staging manual, no staging for intrahepatic cholangiocarcinoma. If you look in the chapter for hepatocellular carcinoma, there was a sentence and said, you should stage intrahepatic cholangiocarcinoma the same, because there was no data. No one had looked at it. There had been some Japanese groups had proposed distinct staging systems, but these staging systems were never validated in the West, and if you look, they didn't really have a lot of prognostic significance. So now, many years ago, 13, 14 years ago, when I was at Hopkins working with one of my fellows, we used our data and we proposed a new staging system for intrahepatic cholangiocarcinoma. And luckily, someone read the paper, and I actually was on the committee for the 7th edition of the staging manual, and they actually adopted our recommendations for the staging of intrahepatic cholangiocarcinoma. So in the 7th edition, there actually is a staging system for intrahepatic cholangiocarcinoma, and recently in the 8th edition, it was updated. So, I think this is one of probably the best things that came out of our work, is that, by working together, we were able to propose this staging system, and it actually got into the staging manual. So when you think about staging intrahepatic cholangiocarcinoma right now, this is the world standard, right? So the T category is based on tumor size, tumor number, and the presence of vascular invasion, with T1A, T1B being solitary lesion, whether it's more or less than 5 centimeters, and then T2 is based on whether there's vascular invasion or multifocal disease. And our group and others have validated this staging system, and it's really the way that we should stage intrahepatic cholangiocarcinoma. That being said, we've had some interest more recently talking about tumor burden score. So the tumor burden score is an aggregate score of adding up all the tumors in the liver and their size to figure out what's the overall burden of disease in the liver. So it's rather than one tumor 5 centimeters, is an aggregate number that can say how high is the tumor burden in the liver. And this is important, I think, because if you look, patients who have a high tumor burden, their 5-year survival is only 17%, and their recurrence-free survival, disease-free survival, only 7%, so very bad. So I think another tool, so a patient comes in and sees me and they have a very high tumor burden using this score, I may treat them with preoperative chemotherapy again, because I know just with surgery alone, it's not that good. And then the other thing that we've done is we've used machine learning, like an artificial intelligence, to try to figure out kind of different classifications of ICC based on size, based on CA19-9, and also based on the neutrophil to lymphocyte ratio, some inflammatory markers. And what machine learning did, interestingly, is it clustered the data and identified 3 distinct subsets of patients. The common subset, the proliferative subset, and then this inflammatory subset. And again, you can see patients in the inflammatory subset in particular had a 3-year survival of only about a year. So again, another type of patient, subset of patient, who seems to do very poorly with surgery alone, and should we be treating these patients perhaps with systemic chemotherapy at first? So that's kind of like the T category, right? You're talking about tumor, the primary tumor characteristics. But the other thing we've had a lot of interest is nodal disease. And as kind of like liver geeks, I say, we love talking about the liver. Should we be doing a lymphadenectomy for intrahepatic cholangiocarcinoma? Right? We do it for fibrolamellar, we do it for gallbladder cancer, we don't do it for, garden variety hepatocellular carcinoma or for secondary tumors of the liver. But we have, over time, come to believe, and I strongly believe that you should do a lymphadenectomy for intrahepatic cholangiocarcinoma. And the reason why is because if you look, these are data are now a little bit old because there's only 500 patients on the data set at this time. These data were published maybe about 10 years ago. But the incidence of nodal disease is about 30% among those patients who have a lymphadenectomy. But you might say, well, half the patients didn't get a lymphadenectomy, right? But what if we say best case scenario? Everyone who didn't get a lymphadenectomy were node negative. The incidence would still be 20%. So the incidence of nodal disease is about 20 to 30% for patients with intrahepatic cholangiocarcinoma. And these are some data that we've published trying to look at preoperatively if you could look at like enhanced imaging models to predict who has lymph node metastases. And the bottom line is you can't. It's very hard to predict who has lymph node metastases. And even patients who have early stage T1A disease, the incidence of lymph node metastasis is still like 10 to 15%. So even early tumors, you could have nodal metastasis. Why is nodal metastasis important? Well, it's prognostically important, right? Why do we do a lymphadenectomy with Whipple or for colon cancer? Do we think it actually prolongs survival? I mean, I don't, right? But I do think it's prognostically important. And it is for patients with intrahepatic cholangiocarcinoma. And if you don't get the nodal disease, then you shouldn't stage the patient at all. Because everything with staging is competing risk, right? So if you're node 0, N0, what's important is whether you have vascular invasion or not, or whether you have a single tumor or multiple tumors. But look, once you have N1 disease, the T factors don't matter anymore. Single, multiple, vascular invasion, present or absent. What matters is you have metastases in the nodal basin. So it's a really important driver to stratify patients with regards to prognosis. And therefore, as surgeons, I believe that we should do a lymphadenectomy. And when thinking about doing a lymphadenectomy, there's a laterality to this, the way the lymphatics drain in the liver. And these are some data, again, from the Liver Cancer Study Group. But if the tumor is located in the right, I typically harvest 8, 9, 12, and 13 nodal basins. And then if the tumor is in the left side of the liver, you really should add nodal basins 1 and 3 because disease can be found in those locations. And in this paper that we published in Annals of Surgery, it's not only important if a patient has nodal metastasis, but it's important where the nodal metastases are located in the nodal basins. And these are data that show if you have lymph node metastases beyond station 12, so like second echelon lymph nodes, then your prognosis is significantly worse. So currently, the AJCC recommends that you do a lymphadenectomy and that you should evaluate 6 or at least 6 lymph nodes, 6 or more lymph nodes to adequately stage the patient. But as most of us know, that is not often achieved. And if you look at data from the United States, only half of patients, only half have at least 1 lymph node evaluated. The other half don't have any lymph nodes evaluated, right? And down here, only about 15% of patients have the recommended 6 lymph nodes evaluated by the AJCC. So a lot of work to be done there. So after we do all this, right, we resect the patient, we stage the patient, what's the outcome? What's the prognosis for these patients? It is overall pretty poor. This is a paper that we published in Cancer. And the overall probability of cure when you take all comers after resection of intrahepatic cholangiocarcinoma is probably in the range of only about 10%. And if you look at 5-year survival, it's in the range of about 30 to 40%. And when I look at this curve, it reminds me of pancreatic adenocarcinoma, right after a Whipple operation. And that's because, it's a systemic disease. I mean, most of us think pancreatic cancer is a systemic disease, even when we're doing the Whipple. And I think more and more of us are realizing that with intrahepatic cholangiocarcinoma, that many of these patients will recur, and that they're going to recur early. And then when they do recur, if you look at the pattern of recurrence, about half of patients will have an extrahepatic site as a component of their recurrence. Again, suggesting that many of these patients have systemic disease when you see them. And this is a paper that we published recently in JAMA Surgery, and this is very kind of depressing news, right? 1 in 5 patients actually had a very early recurrence, recurred within 6 months of their surgery. And so I think in the future, using tools like this, we need to identify those patients who are at very high risk of recurrence. As I mentioned earlier in the talk, those patients who present with FDG avid nodal disease, patients who present with multifocal disease, and treat those patients like we do pancreatic cancer patients with preoperative chemotherapy to figure out the biology before we take them to surgery. And you can see here, again, patients with multiple tumors or lymph node metastasis, very high risk of recurrence, right? And right now in the United States, there's a clinical trial that is open that is exactly looking at this, that patients who present with high-risk features are being treated with preoperative chemotherapy first before being taken to surgery. So I'm just going to wrap up a little bit about some of the systemic options that we need to think about, because I think just like colorectal cancer, and I even say like pancreatic cancer, many of the advances that will expand the indications for surgery will be based on progress that's made with systemic chemotherapy, right? Like look at colorectal cancer now. We operate on things we never would have operated on in the past. Why is that? Because we have much better systemic chemotherapy and targeted therapy. So with cholangiocarcinoma, I'm sure you're all familiar. This is the data from the ABC trial. This is advanced biliary cancers. These are patients who had were not operated on advanced cancer. They were treated with either monotherapy with GEM or doublet therapy, GEM-CIS, and this study showed that there was a benefit with a risk reduction of about 35% for doublet therapy, and that's why most of the time we're using GEM-CIS to treat patients with systemic chemotherapy. Now, there's been the Prodigy 12 and the BILCAP trial. These are trials that looked at adjuvant therapy. And these are patients who have gallbladder or cholangiocarcinoma, but it could be perihilar or it could be intrahepatic. And in the Prodigy 12 trial, they looked at a GEM-OX versus observation, and there was no difference. It was a negative study, no benefit. And the BILCAP was a little bit more confusing. They used capecitabine in the adjuvant setting, and on the intention to treat, it was suggestive of a benefit. But then when they looked at the protocol analysis, there was a benefit. And so many people, at least in the United States now, have adopted these data, and patients who are treated, undergo resection for intrahepatic cholangiocarcinoma are treated with adjuvant capecitabine now, especially if they had high-risk features or the nodal metastases and things like that. I think going forward, though, really we need to focus more on targeted therapy, right? And now we're coming full circle for my talk. At the beginning, I highlighted these molecular targets, and there has been lots of interest around FGFR. They can be point mutations, but more importantly are these fusions. And there has been actually pretty impressive responses in a certain subset of patients with FGFR targeted therapies. You can see a couple examples here. And because of data like these in the United States, FGFR targeted therapies are approved for second-line treatment of patients with advanced intrahepatic cholangiocarcinoma. And you can see this is a waterfall plot looking at response to FGFR therapy. And then, as I mentioned, IDH mutations in 10 to 15% of patients. And this is the Clarity trial that shows that there was a benefit of isofenib versus placebo in patients who had IDH mutations. BRAF, so now again we're getting less common, but you can target patients with a BRAF mutation, and you can see here response, immunotherapy. Responses are relatively modest, again about 5 to 10%. And then probably the future is combination therapies, right? Combination therapies rather than monotherapy with immunotherapy alone is the combination of targeted therapy with perhaps traditional systemic cytotoxic chemotherapy. And here are some data that were published at ASCO GI looking at GemCis plus durvalumab, showing that there was a benefit from combined therapy versus GemCis alone. So, at least in our center, we really recommend that these patients be molecularly profiled because if they're inoperable, most of them will need second-line therapy, and if they're operable, a lot of them will recur, and then when they recur, they'll get standard therapy, but typically the response rates for that are not that great, and then we will move to second-line therapy that will be informed on their molecular profile. And we try to use tissue-based testing and not cell DNA testing because you can miss things. And in particular, with FGFR, we're not looking for a mutation, we're looking for a fusion. I didn't go over some of the data, but in the data looking at FGFR targeted therapy, patients who have mutations actually didn't respond that much. It was really the patients with the fusions, and that's why you should always include RNA-seq to look for these gene fusions. And again, I think it's important to look for that tail. We're thinking FGFR, we're thinking IDH, but there's other patients who may have other perturbations in their genetic profile that can be targeted with different agents. And then I just threw this slide in here because we were talking about this morning about pumps. We actually still put pumps in, hepatic artery infusion pumps. We actually put them in robotically. I don't, my partners do. That basically, we put this pump in subcutaneously, and we put the catheter into the gastroduodenal artery. And the group in New York at Memorial Sloan Kettering is published on this. This is a paper that we recently published in JAMA Surgery. But this can be effective therapy, for patients who have large, bulky disease in their liver for intrahepatic cholangiocarcinoma. I think a pump is actually not unreasonable. You can have some fairly dramatic responses, and there's even a subset of patients who can be converted from being inoperable to operable by putting in a pump, having significant reduction of the size of the tumor, and then subsequently taking them to operation. So I think just another thing to be thinking about, at least at our institution, to treat these patients. So with that, I'll conclude. Hopefully what I've told you more than you probably ever wanted to know about intrahepatic cholangiocarcinoma, but I think it's important because it's a disease that I think we're going to be seeing more of. The incidence is increasing. These are challenging operations, large tumors, big operations. When we operate on these patients, obviously we need to get a margin negative resection, try for a centimeter negative margin. I think we should be doing a lymphadenectomy at the time of surgery, and I've discussed what type of lymphadenectomy based on the location of the tumor in the liver. But unfortunately, even with the best surgeon, the best hands, recurrence is common. It's frequent. So we need to move to better selection of patients for preoperative therapy. And then I believe strongly that we need to be molecularly profiling these patients and working very closely with our colleagues in medical oncology, entering these patients on the clinical trials, and then also offering them a kind of more tailored, personalized medicine approach if we're going to hope to improve their outcomes long term. So with that, I'll show you, this is our medical center here. So this is our cancer center. And then this building here is our new hospital that is getting built. And then that's the city of Columbus in the background. And hopefully you'll one day get the chance to visit me, as I've had this wonderful chance to visit you all today. So with that, I'd like to thank all of you for your attention, and most importantly, I want to thank my wonderful host and my wonderful friend, Professor Popescu. I am incredibly honored and humbled for this invitation, and I just recognize all you have done, not only for this institution, not only for Romania, but for surgery around the world. And many of us in the United States and other countries look up to you, as a real leader and pioneer in liver surgery. So I call myself very lucky to have you as a friend. So thank you very much.
Thank you very much. Thank you very much.